I started to see patients during residency, obviously, in the field of psychiatry, right? Um, in the outpatient clinic, in inpatient, but mostly in the outpatient. And I remember that I was doing sort of my best to stick to guidelines. My mind was filled with the do's and don'ts of the standard of practice. And after all, I passed my boards and pretty much proved my capacity to comply and assimilate a large uh, amount of information within a short window, which is pretty much done by not questioning what you're learning and kind of also a measure of compliance. But in those days, every so often, a patient, fairly rarely, a patient would say, I'm not taking the medication every day. I'm not taking my medication as prescribed or anything like that. And in those rare cases, I would go like, encourage compliance, right? Okay, hey man, you got to take your meds. That's how they work, blah, blah, blah. After I finished residency, I had 4 years of work in an inpatient unit. And, I was feeling pretty proud of my prowess, in following reasonable treatment guidelines. And I was trusting the treatment guidelines and things like that. After that, I left for outpatient psychiatry and residential substance use treatment, like detox and rehab and outpatient drug and alcohol treatment as well. And then I started to notice something that was off. So I was seeing these patients that are desperately trying to stay sober being prescribed a lot of addictive medications. And when I say addictive, I don't mean habit forming, because everything we prescribe in psychiatry is probably habit forming in the sense that the brain gets adapted to it. Once you remove that molecule, now the brain is left without it, and all the compensatory mechanisms have to fall back, and that may be what we call withdrawal from a physiological perspective. No, I'm talking about medications with self-reinforcing properties, like street value, so to speak. I remember even covering for someone who worked in a different state under the same institution, and about 8 out of 10 patients of that provider were taking Suboxone, clonazepam, and Adderall. And I'm not even talking about the other types of medications where it's somewhat questionable, like gabapentin, Seroquel, and Wellbutrin. Wellbutrin, if snorted, people call baby cocaine and things like that. And of course, I got into a few fights as a result of that. And during those fights, what I would hear when I would share my concerns would be like, well, we don't know that. Like, for example, we don't know if gabapentin increases the chances of relapse in someone who has issues with alcohol, or the opposite. Someone would say, well, maybe benzos or gabapentin will keep you away from alcohol, just the same way that Suboxone has some impact on your use of street opioids, right? The funny part is that used to be that if you don't know if something's safe in medicine, you don't do. But that, of course, has changed a lot. And what I did was I went to check for data to support that kind of thought, and I even found out there's a sort of a thought, not bias, is a thought, sort of a thought trap, a mechanicistic thought. So if Suboxone and methadone are bringing some benefit for opioid users, then stimulants should bring a benefit for cocaine users, and lorazepam and gabapentin should bring a benefit for alcohol users. It turns out it's not the case. Things are clearly more complicated than that. But from that gig, I went to another outpatient psychiatric place, and I continued to see a lot of cognitive pitfalls, if you were to call, for the lack of a better word, it's not coming to my mind right now. Things like, for example, all anticonvulsants are mood stabilizers. right? I started to see that, like crazy medication regimens. Gabapentin is a mood stabilizer, regardless of the gigantic lawsuit in the 80s because of false advertising as such and absolute lack of evidence. A lot of people diagnosed with bipolar on gabapentin, things like that. Lamictal is approved. If Lamictal is approved for bipolar depression, it should be good for every depression. Also, benzos being prescribed left and right chronically, despite the lack of evidence of its safety in the long term. If anything, the opposite. Most of the time when we look to chronic use of something, we find just bad news, right? Especially with benzos, we found that chronic use is bad for you. We don't have anything saying that's safe, but that's how medicine, because it's an art, ends up being. You have this stretch of limited evidence. We have opioids bringing benefit acutely. Oh well, then we're going to put people with chronic pain on opioids for the rest of their lives. We have antipsychotics showing under some measures some benefit in the short term. So the conclusion is that if you're schizophrenic, you have to take for the rest of your life. And benzodiazepines make you relax now, so you should take for the rest of your life, and so forth, so on. Right? We covered that already in a previous episode. And there's also another trap that when you see crazy medication combinations, people would say, well, there's nothing saying you cannot. And I mentioned this back in the day when the podcast was called Psych Experience, and I only have this episode on Spotify and Apple podcasts. I think it was called Oral Tradition in Psychiatry, this thing about, you saw someone doing, or you asked someone, can you do? And the answer, yes, you can do. You can do freaking anything. Everything's good for everything in this field. So you end up, having this sort of a salad of medications for every persisting presentation, because all presentations are stemming from the reality. I don't want to go there. Anyways. But then, all the kinds of mixes that we see. Dopaminergic agents prescribed at the same time as dopamine blockers. I was almost unable to sleep those days, right? Because I started to look into these things and realized that as a result of that frequent of my contentious personality, I ended up reading specific topics, looking for support or lack of support for things. And I started to notice that a lot of the things we do were not supported by data whatsoever. And I said, you know what? Let's start a podcast to talk about these things, right? To kind of clean up. Let's start a podcast to show people that intuitive prescribing is not a thing, shouldn't be a thing at least. Let's stick to guidelines. Which brings me to the topic of this chat. As I started the podcast, and as I'm learning and changing the way I do things, I started to get in touch with researchers and thinkers of the field like Joanna Moncrief, Dr. Horowitz, Ron Bassman, and more recently, Dr. Paul Andrews. And the commonality between all those folks was their crushing ability to apply logic to matters in psychiatry and be attentive to the scientific method. Now, I know the plot is thickening a bit, but bear with me for a second. What the scientific method implies? The scientific method implies that when you have a hypothesis, you just don't look for the things that confirm your hypothesis. You also have to make an effort to see if you can prove your hypothesis wrong. Right? Because if you only look for the positives for the confirmation of your hypothesis, we call that confirmation bias, right? So the thought is that by failing to prove that something is not, you may have a chance to claim that something is. Let's take an example. So let's take, for example, antidepressants, right? So you give a molecule to a patient, and the patient says, well, I'm feeling better. My mood is better, let's say. And then you're going to say, well, that molecule is an antidepressant. Under that logic, we should call benzodiazepines, alcohol, nicotine, probably chocolate antidepressants, right? Instead, from a scientific perspective, we think, well, what if that's just the action of giving something, right? Considering the amazing impact that chocolate has on my mood, for example, or alcohol and nicotine. So then we create the placebo-controlled studies. But then someone very smartly will say, well, medications have side effects. Placebos are inert. Can we really compare them both? So then we go for active placebo, right? Placebo studies. Studies using placebo medications, atropine, that has side effects like drying your mouth. And then you cannot tell if you're taking a tricyclic or a placebo. And, sure enough, we find no meaningful difference between active placebo and in a handful of studies, right? We didn't have too many for obvious reasons. But we didn't find meaningful differences between the placebo group and the antidepressant group because they all thought they were taking the active medication. And then there's other things like, for example, counting the number of negative randomized controlled trials compared to the number of positive ones, just like Dr. Kirsch did. So, for example, sertraline, I think, has 4 negative randomized controlled trials, but 2 positives. And, FDA only takes 2 positives regardless of how many times the medication has failed. It only takes 2 positive to approve for a given use. I think Celexa had 1 decent study that was negative as well. Then we have Lamictal with maybe, I think, 3 negative and 2 positives randomized controlled trials for depression associated with the diagnosis of bipolar disorder. So you see, if you look to find why not what I'm thinking, which is very counterintuitive, and you find a lot of reasons why not, then maybe it's not. Like it makes you question, are antidepressants actually antidepressants, or they're doing something else, right? That may be perceived as such or may be useful. I'm not denying the use of antidepressants. I think, we just haven't looked where drugs can actually be useful under that perspective. And then there's other factors as well that, like the vast evidence backed by crushing logic, that depression, for example, once we talk about it, is not caused in the brain or by the brain. Instead, is a result of the interaction of the brain with reality. And as such, the cause of depression is in that relationship. Now, what's the result of this journey of mine? The result is that I became, in contrast with what I told you in the beginning of this chat, enforcing compliance kind of talk, I became less invested in medications. Before, I would see my job as doing a proper assessment to choose the one appropriate agent or many, and then ensure their compliance. But as a result of this journey, I started to see my job differently. I'm no longer a medication chooser or a compliance enforcer or a med tweaker. Now, I confess that I don't have an easy way to summarize or describe what I believe my job is nowadays with like one statement, like I just did with my older version. But that also seems appropriate considering the complexity of human behavior and the complexity of the task at hand. It seems appropriate that I don't have just a plain phrase to describe what psychiatry is. And as such, I decided to adopt the expression true psychiatry, as much as I, as a proof of my belief on what I've been doing. But maybe we could describe it as a mist of 2-degree changes in our current practices that still manage to fulfill legal standards of care, but in a rational way, taking unbiased data into account as well, not only financed bias, financed by pharma bias, or with all due respect, brainlessness of our diagnostic criteria, which I still believe has a use. Don't get me wrong. It's just that it comes with implications and assumptions that are not true. But like thinking of examples of those 2-degree changes, I started to use shared decision making, right? Like I spoke in my previous episode. I started to perform actual informed consents, where I talk about the medication for what it can do from a statistical perspective, without minimizing, because I don't have a horse in the race. I'm presenting information to the patient saying, you could take this, this is how it could go, the decision is yours. Another one would be establishing a baseline for the presentation that my patient is telling me about before I make any meaningful interventions. Now, the importance of establishing a baseline before an intervention you can find in a book called The Scientist Practitioner by Hayes and Barlow, written ages ago, but it's very good. So what happens to you once you're no longer a medication chooser or a med tweaker or a compliance enforcement? What happens to you once you're no longer invested in thinking that the entirety of your job consists of prescribing a medication? In other words, what happens once you start acknowledging to yourself the limitations of that practice? Well, what happened to me was that the number of patients I have that would admit taking medications in a PRN fashion, sort of, right, or not taking regularly, just skyrocketed. The number of patients that would come to me that I would inherit from other providers with a given medication regimen just look at me and say, I haven't been taking them. The number just started to go up, like a lot. Somehow, as a result of my change, my patients became comfortable telling me that they don't want meds, or that they're taking them in a different way than prescribed, or taking them with low frequency. I'll give you a few examples. So, for example, I've had a lot of patients that will tell me they take antidepressants as needed, which in the past they'll say, well, for antidepressants to work, you have to take every day. But I have this large group of patients, fairly large, saying, I take when I'm not feeling well, when I'm down, when I'm too anxious, when I'm overwhelmed. I take for a few days and then I stop, right? And it helps me a lot. Obviously, they have minimal side effects compared to the patients that take medications every day. I have had patients who met criteria for bipolar disorder, or that would report a convincing story for mania, not what we call mania nowadays, like someone that would meet criteria for mania 15 years ago, when the prevalence was still 2% as opposed to 10 as it is now, before the expansion, they would tell me that they would take things like, I take Depakote when I feel funny, when I feel I'm started to rev up, when I feel like I'm more talkative, when I feel any harbinger experience that sort of usually is associated with mania. Patients will take as needed Depakote, as needed benzos, as needed antipsychotics, you name it. The same for, and they will feel comfortable telling me that. And of course, they will have minimal side effects, normal body weight, no diabetes, no high cholesterol, right? And report success. They would say, I remember a patient saying, I don't like the way it makes me feel when I take, but I can tell I'm kind of feeling funny, and then the next day I feel a little bit funny, but then after that I'm sort of back to what he would call a baseline with, the normal mood fluctuations that we have in everyday life. So what to do with that information? What to do with this level of disclosure that I'm seeing right now. Now, if you look into the data, for example, supporting for take into account bipolar disorder or bipolar syndrome. If you look into the data supporting chronic use of, say, Depakote in mania prevention, it's not that convincing. It's not that convincing for Seroquel either. Now, the one that is the more compelling one is lithium. However, the research on lithium is loaded with flaws, and there's a lot of discontinuation studies in the old seminal studies on lithium. A lot of them were discontinuation studies comparing lithium continuation with lithium discontinuation, and they were not doing any particularly careful tapers of lithium, which now we know is associated with mania, right? So what do I do with it, right? Well, the first step is to have from the patient's report something as close as an objective measure as you can, or a report of how they're doing, right? So, for example, for mania, considering mania before mania became fashionable, we are talking about very low frequency manic episodes. So you have to try to figure, okay, how frequently were you having these manic episodes and how frequently you're having them now? And that's a very hard to answer question. It's not an easy task because it's a low frequency event. It's not like nowadays, I had 3 manic episodes, one in the morning, one in the afternoon, one at night, because that's what the diagnosis of bipolar has become, thanks to the work of a few well-known psychiatrists around the world. But that's a very difficult task to perform. But what do I do with that, right? Do I encourage compliance, or I support the patient and follow his lead, considering his reports of perceived benefit? Well, I don't do either. I inform, right? I expose the formal recommendations. I expose their potential biases. I expose the limitations of the research. I expose what most doctors would recommend. I expose that we do not know, for the most part. I expose the consequences of a failed treatment, which the patient frequently knows, and I give the decision back to the patient. But that's not the topic of this episode. So the topic is how the hell it is possible that so many of my patients are resistant to meds much more than before and are admitting to me that they are not taking them as prescribed, compared to before when I was more of a believer in that kind of a paradigm of treatment. Now, you may be listening to me and thinking, nope, it's a problem with you, Rod. You're doing something. You're misleading your patients. You may be thinking that I am the exception and that you, with your perception that most of your patients are actually taking the medications as prescribed, is the one who's right. But I have bad news for you, because when you look to the data about medication compliance, and I have a few here I'm going to read for you. So we have a paper by Haddad in 2000 that looked into a group of people, and he described good adherence with taking the medication as prescribed more than 80% of the time, medium adherence to 50 to 80% of the time taking as prescribed, and low adherence taking less than 50%. Now, that's very arbitrary. Why not 90%, 60%? It doesn't matter. Just take a look at this. So that paper found that 42% only, so it's less than half, had good adherence. It doesn't really cover what's the percentage of 100% compliance, right? But it really tells me that my change in attitude allowed me to see reality, which may suggest that if you're still a believer in our current paradigm of diagnosis and treatment, and you have the perception that all your patients are taking the medications, chances are not on your side. I also found an interesting paper by Kramer, Klein, and Fink, Withdrawal Symptoms Following Discontinuation of Imipramine Therapy, American Journal of Psychiatry, and they found that time use of imipramine was associated with more withdrawal symptoms, which is kind of a point for poor compliance. Then another paper suggesting, I'm going to read here, Ravi Lingman and Jen Scott, Acta Psychiatrica Scandinavia, 2002. Recent studies will suggest that about 30% of patients stop taking antidepressants within 1 month of starting them. 45 to 60% stop the prescribed treatment by 3 months. And furthermore, up to 50% of depressed patients discontinue antidepressants in the maintenance phase of treatment. So it seems that my new style of work, new so to speak, it's allowing me to see reality better despite hopes in the contrary. What other interesting thing happened as a result of my in my practice, right, as a result of this discovery journey that I went through? Well, there are many, many others. I just want to share this other one for this episode. It became much more easy for me to establish a baseline for the problems that are presented in the office. In that any problem, auditory hallucinations to low mood, because you see, traditionally you have the intake, which is this longer conversation than a follow-up, and by the end of it you have a treatment plan and you offer medications. That's usually what happens. Now the thing is that once you stop making decisions for your patients and you start working on informing your patients about the known and the unknown, things about diagnosis and treatment in the field of psychiatry, the patients become much more cautious with taking medications, or they were already cautious before and we didn't know that. Now they're just being honest about their caution when it comes to take medications, because they can see that I'm no longer a medication-only guy. I have medications as a resource, but I'm much more focused on figuring the big picture, what's missing, right? What's causing you to feel this way. And as a result of that, surprisingly, I would say that, and this is quite concerning for the field, but I would say 8 out of 10 patients, maybe a little less, at times a little bit more. It's hard to precise, but the absolute majority of my patients would say things like, well, when I present side effects, when I present what could go, could not go, and I give the decision to my patients, they say things like, let me think about it. Let's sit on it for a month. Let's put a pin on it. Let's review this thing. Let's see how I feel in a month down the road. That allowed me to learn another thing, that and the same for just being conservative with whatever you find. People will come to you taking medications and say, man, it's not working. It's the first time you're seeing the patient. And then you don't touch it, right? And then the patient comes back the next time saying, I'm better. Or it comes back the next time saying, I'm worse. And now you know that whatever fluctuations happened by other factors, not our puny medications. So picture this. Someone comes to you and is taking, let's say someone says, oh, well, I spoke to my PCP. I have high cholesterol. I have diabetes. And then you see that he's taking Seroquel to augment an SSRI. And you explain that to the patient. You say, well, man, these things could be caused by your Seroquel. And then the patient freaks out. They say, well, if we stop that, I'm going to feel worse. And you say, well, we don't stop. I'll see you in a month. And if the patient comes back feeling worse anyways, you see, what was this medication supposed to do? And the opposite is also true, right? People come to you in a first appointment. They're much more likely to be focused on the negatives to make do, because they've been waiting forever for this appointment or whatever other factors. And you present these things to them and they say, well, now that you're talking about it, I feel more inclined to entertain my problems and address them as opposed to take a pill. You can change people's motivations based on that. And, the patient, of course, is going to feel better. And then you can change people's motivations based on that. And, the patient, of course, is going to feel better. And then you can change people's motivations based on that. And, the patient, of course, is going to feel better. And then you can change people's motivations based on that. And, And as a result of that, the patient comes back a month later and he says, I'm somewhat better. And you say, well, you see, we didn't prescribe it or we didn't touch anything. And then he comes back another month later and he says, I'm not so hot anymore. But then you start showing the patient and yourself, right? But mostly the patient, because we know everything, that their mood is fluctuating despite stability of the drugs. So that helps people to entertain. Well, then what is causing it? What is that is upsetting me so much that maybe I don't want to look into, that I want to suppress? What hurt my feelings and I don't want to admit? Things like that, suppression. And then you start having a much more productive interaction with your patients. Anyways, that was the topic for our conversation today. Thank you for listening and thank you for following. If you find this conversation to be useful, please share with someone you know.